Hello, everyone, and welcome to Africa Fire Mission's weekly virtual training session. My name is Mike, and I'm the programs director here at Africa Fire Mission. We're so happy you took time out of your busy schedules to join us for today's training session. Today, we're going to continue with our sort of monthly topic of EMS. We're going to be looking at some traumatic injuries, some bone injury. Uh, so we'll get started with that in just a few minutes. Before we get started with that, though, we're gonna get some words of encouragement here from Jose. Jose is Africa Fire Mission's fire safety officer. So, Jose, you want to share a few words with us?
Sure. Thanks, Mike. I truly appreciate you. Thanks, Aaron, also for inviting me, and everybody else. Thank you for being here. We actually don't take this for granted. I just want to let you know before I say my words of encouragement, you don't know how good of a favor you're doing yourself by always being here. This continuous assessment learning is a point whereby you bring yourself to the realization that you need to constantly remind yourself how to be better in the fire service. Because in the fire service, it's not really about you, it's about what you're called to do, and it is about the people that you're going to serve. So yesterday night, I was actually attending what we call it, a memorial for somebody. Not really a memorial, but a burial arrangement. One of my friends died, and there were, something came into my mind. You know, in the midst of uncertainty and loss, you know, like as firefighters, we actually run towards the flames. Yeah, not away from it. And that is a reminder that we must face life's hardest moments with courage. In the midst of fear, we go to the fire, but it doesn't mean that we're afraid. But in the midst of fear, we still have that courage. Yeah. Fire teaches us something powerful. Even when everything seems to be going up in flames, what survives is strength, unity, and purpose. So, what is the main purpose that you are brought to the fire service to do? You may feel like you're walking through fire right now, but you're not alone. Like whatever you're going through, be it a loss of somebody, be it maybe you're being auctioned, be it that maybe you're not, your bosses are not on your side. Guess what? You're walking through fire right now, but guess what? You're not walking alone. So you need to actually get people who can walk with you, stand with you, and carry you when burden feels too heavy. Never do it alone. Flames may roar. The flames can be what I'm talking about. Your work may be difficult, the loss of a good of your relative. Yeah. Just know that like gold refined in fire, your faith, love, and resilience will shine even brighter on the other side. So you need to hold on. Help is present, hope is real, and healing is ready on its way. So guess what? Even as I finish, stay strong like the firefighter who knows the heat but doesn't back down. You are braver than you even know. So reach out to anybody around you, around your workplace. Reach out to your friends. Don't feel like, hey, I can manage this. I'm strong. I'm a man. No, just reach out and you might find that your help is right in front of you. Stay blessed and keep it locked to this great lesson that is upcoming. Thank you very much, guys. Back to you, Chief Mike.
Thank you, Jose. We appreciate that. You always coming and sharing those encouraging words with us, keep us going there. Good. Somebody said in the comments section, positive vibes today. Very good. Uh, Thanks, Jose. Uh, After we get completed today's training, at the top of the hour, we transition into our tea time, and Jose and Errol, who Errol is our fire safety advocate. He's going to be helping us host that tea time afterwards. Tea time is a place where you can ask some questions about today's training, or just a great opportunity to do some networking with your fellow firefighters from throughout Africa. Take a look at the chat there. We've got people from all over that are joining us. Keep dropping your names and where you're at there in the chat. It's cool to see where everybody's from. We're going to get started here just a moment. But before we do, I guess let me touch on just a few administrative items. If you stick around for at least 70% of today's training, which is usually about 40 or 45 minutes, you'll receive a certificate of attendance for today's training. Uh, if you get stuck or you get cut off or something happens, there's still opportunities for you to receive those certificates. If you head over to our webpage, www.africafiremission.org, go to the resources tab. There's all sorts of great stuff there, but if you hit the resources and then training materials, there'll be a link in there to a Google Drive folder that has a recording of today's training. It'll have a recording of all the trainings that we've done so far this year. You can answer a few questions, show us that you learned something, and we'll get you a certificate of attendance for those classes as well. Check out our YouTube channel if you subscribe to our YouTube channel every Friday morning at 8 a.m. East Africa time. Those recordings from our trainings come out, so you can also catch the recordings there as well. Check out all of our different social media that we have available. Lots of great resources and great ways to connect with us. All right. At this point in time, I think we're going to swing over and get started here. Let me just make a quick adjustment here and see how we're doing. Richard, are you with us?
Yes, sir. How are you doing, sir?
Very good. It's all you, brother.
Yeah, sure. I've been doing well. Thank you. Oh, yeah. Thanks so much, Jose, for such a very good and informative session there. This guy is always oozing with encouragement, because sometimes I know I call him the times that I feel like things are not working on well on my end. And I'm really, I really go with this way for him to always be like he's a pillar. He's also he's a good brother to always lean on. And then we have Chief Mike here, who is always here to tell us and to give us good things. So for today, we're going to do traumatic injuries. These are injuries that goes from minor injuries. We say like trauma is something that you got either from a kinetic or from something knocked you down or knocked you up, if there's something like that. Chief Mike, I don't know if you can be able to share the slides on your side. I'm trying to look my machine. Yeah, please. I bought a new machine and it's really misbehaving. I don't know, sometimes you don't know how to go through it.
That's okay. I got you, brother.
Sure.
Let me just get my sharing going here. There we go.
Yeah, good. So today, generally, we're going to do, we say like we're going to talk about injuries. That could be you're walking on foot with what you call here. Chief Mike, I know you know them about the Crocs. And then you'd knock with the stone when you're walking on the road. And it's part of injury, and we'll classify them on musculoskeletal. This is the muscles and also the skeleton, which are the bones that we have. And we look at general practitioner, general view, how we can be able to, you can be able to actually tell this patient of mine is suffering from an injury, and how to easily treat that injury as we move on. So we can go to the next slide, my chief. Yeah, this is what we are talking about, because the body framework, or what you call the structure of like the structure of building, is the walls, the pillars, the roof, the floor. For here we have the bones, which generally give us the shape. And then we have the joints that help us, like when you move in, use the knee, the ankle, the hip joint, the elbow, the wrist. And then we have the muscles that literally help in movement, and also gives us some little bit of shape when you are not so that bony. So if you go to the next one, we'll find that these are the cartridges. They're very flexible. For example, what we find in our ears, and then in our the shoulder, the scalpel, which forms the part of the shoulder, the hand. We also have ligaments. These are the what connects bones to bones. We have tendons, which connects muscles to bones. These are where we find, we have sprain, we have strains, and then we get people with, basically you hear people tell you that he has a muscle tear. So the bones are what gives the collective body tissue. It's a very form, they're dense. When they break, you'll end up having some deformities here and there. They also help to cover the peristenium. This is what the muscles do, and then they help to cover it down. And then we always have these are generally bones that we have, a small number of bones that the human beings have, and then we're going to concentrate with the structure, and also this is just to give us an overview of what happens after you were injured, or you get some you fall from height. You realize that most of the bones that we have, they have regular shape. They have a definitive shape that is according to its functions. This one you also have some bones that are very long, like what you have the femur. We also have the tibia, the ulna, the radius, the fibula, and then we have some short like for example, what is found in fingers. They're very short, and then we have the flat surface, which mostly you get it on the arm at the scalp or the shoulder giggle. So as we move on, you see, this is what we are saying. You see, some of them are they have flat bones. Also includes the lips. You can see on the presentation here, we have a flat, which is a scapula. And then we have a long bone, which is the humerus, the bone connecting the ulna and the radius. And then we have short bones that already said that you find them in hand and the legs. And we go have an overview of for examples of muscles. We have the skeletal muscles, we have the biceps, we have people with the six-pack, as we call them. And then we have the cardiac muscle, which is the heart that excites on rhythmically, that helps us the blood which helps the heart to pump the blood. And then we have smooth muscles, which are found inside the stomach and also the small intestines. Moving on. We also have, this is what we're calling the muscles and the bones. You see, we have a tendon, like for example, what is found in the knee. we have the muscle that connect, the tendon that connects the muscle from the thigh and also that connects to the kneecap. Then we also have the ligaments, which connects mostly in joint, bone to bone through a joint. And when we feasting on our chickens and we have to break those wings and those drumsticks, you always find some. We always come across finding ourselves chewing on the ligaments. It's a little bit tough, not tough as a bone, but really that's what helps in joining the bones to bones. Then we also go to the next where we'll find the general guidelines of what to do on emergency care, what to do in case you find someone in such a situation. For example, you'll find someone with a broken bone. How do you treat that? You find this is what we'll give. This is an overview. Like most of the forces that we get, someone knocked you with a wood or a piece of metal. That's a direct. And then we have something that happens. We also have injuries that are indirect. Yeah, things that happens from inside. And then we have twists or return. We see them in WWE, where you get someone literally rotates the other person's hand from behind, and then it's super painful. You'll have some of this injury. That's when we have the muscle tear. We also have the spring and the strains. We also have fractures that are as a result of direct hit, or indirect is purely means the bone fractured. The bone is broken. It can be either be two part. It can be either be in two. One, it means the bone fractures and tears the skin. That means it's an open wound. You can see there is blood that is flowing outside that part. Then you have someone that have closed. The skin is not broken. And how do you know there's a fracture there? We're going to see it in a few. We also have committed fractures. These are fractures that happens in several divisions. Like you'll have bilateral broken bones broken. We'll have like for example, what happens in a high velocity motor vehicle collision is where you can get someone that has one leg has broken into small different parts. Then we have green sticks. Green sticks mostly happens to children because their bones are not really rigid. They are kind of flexible. Like what you have, if you ever try to break a green stick or a stick that is not so dry, you find like it have some hairline fracture. It will have some hairline. That's what we call a green stick fracture. Then we have angulated. These are when the bones in an angle. For example, it happens mostly with the ankle and also the elbow part. That's most giving an example of angulated. Then we go to the next, or we'll find now we find that it's one of the most painful injuries you can ever have. This means we have both the tibia and the fibula, that one of the bone is literally out of the socket. And you see, if you look at this, we don't have blood, or the skin is not broken yet. So we can also classify this as a closed fracture because you can't see a wound inside with that. So we also have dislocations. These are parts that comes apart in a joint. Then you have we talked about the strains, the stretching of the ligaments mostly happens with contacts games, for example, football, rugby, the American football also. Then we have strains, the overstretching, overextension of muscles. These are when you move in and then you slide, and then one side, one muscle goes to the extreme of normal stretching. Then we go to the next one, where we'll find like not all injuries can be confirmed as fractures in the field, because literally when you go to the hospital, you always say like, we need to do maybe an X-ray, we need to do a CT scan so that we can be able to check exactly what has happened below the skin. So it helps us to do when sprinting. If you're not sure there is a fracture, it's better you treat it as a fracture, and then you sprint the extremity or the leg or the hand with caution, as we're going to learn in the next few slides. So when you sprint a slide, it helps you to bring it at least makes it to minimize on pain. Then the other thing we need to be very careful is, before you do everything, we need to check for ABC. This is my patient breathing? Is the airway open? Do I see any catastrophic or profuse bleeding? So that, remember, what will kill this patient first? It can be either be a blocked airway, the patient is not breathing, and then the blood is moving out of the body. Then the other thing is, when you want to remove the patient's clothes, please do not strip them naked. If you have to do that, make sure you uphold the patient's dignity. Because when you can imagine a situation that when you get the full clothes out of that person, and then the public is there, and with the generation that we have, we always love taking pictures. We always like posting on YouTube. We like posting on TikTok. We will find yourself someone posting there. So moving on, we'll have some. You end up having some swellings across the extremities, across where there will be a suspected injury or suspected fracture. You also have some crushing injuries causing bleeding swelling in. It might swell from it. You might have some blood correcting below the skin, and you'll notice that by when you see, and then you see like exactly the color changes. If this person is, you can see the difference with their jack, and then you get some black spots that were not there initially. So if the patient can talk, you can talk to them. Form a rapport. This is where you need to ask them some basic questions, and then they can be able to tell you what to do next. So when there is too much swelling, of course, perfusion will be stopped. Perfusion is when the blood flow, or the flow of the blood will be interfered with. So when there is also a progression of the cells will be damaged in one way or another, because they're not receiving enough oxygen, and also the blood supply will be stopped. So you might have that leg on the, if it's not well managed, the victim might lose their leg, might lose the hand. So we need to restore blood or normal flow of air, of blood and nutrients to that side, as we're going to learn them in the next few slides. So you'll when you're doing patient assessment, this is when now you go to give that care. If the patient can talk, they will tell you they're feeling a lot of pain. It is very painful. Then if you compare the two sides, or what you call the if it's a leg, you compare the leg with the other leg, one of them will be deformed. Maybe it will be twisted, there will be swelling, to be they will see like they will not be uniquely, or they will not be there will be some special effects from the injured leg. Then there will be swelling and bruising. When it's an open wound, you get some exposures, you see some blood, you see some bone parts, and the joints, joint is supposed to move, so it will be locked to position so that like this patient cannot be able to move their leg, their hip. Then there will be compromises on blood flow and also the nerves. That when you go, you'll do the CSM. The CSM simply means you check for circulation, you check for sensation, and then you check for motor function. And how do you check for circulation? You check for their pulse. How do you check on how do you check on CSM? The motor function. You tell them to try and wiggle their toes. We have the 6 P's, the basic 6 P's of assessment. So number 1 is pain or tenderness. We have the pallor. Pallor means the skin color or the skin condition. They also have, you also feel the tingly sensation. This is when you feel like there are some small needles and pins that are trying to puncture. Then the pulse will be gone. They will not be able to control, they will not be able to lift, to wiggle the toe. And then if you do the blood pressure, it will be low. So when you were doing the patient care, standard precautions must be done. Remember we said, if it is sticky, it is wet and slimy, and it's not yours, please wear gloves. Then the other one is primary assessment, the ABC. That's when you do the airway, the breathing, and then circulation, you check off deformities and also exposure if there is need for. Then during the secondary assessment, we always know most of our fire engines, we don't have the seat collar. Is where now we need to have a collaboration between the ambulance guys and also the fire engine guys. So if you need to do a splint, if you suspect a fracture, it is better you do a splint, because you never know what happens inside. But when you need to do a splint, you need to have, that's why we said we start with primary assessment. That's when we do the air with the circulation, the breathing. We cannot be able to emphasize more on that, because if the patient is not breathing, they'll die from lack of oxygen. If the patient is losing the blood, they will die because they don't have blood inside the systems. So cover the wound with a sterile gauze or with a sterile dressing. If you don't have a sterile dressing with you, you can use a clean piece of cloth. So when we're doing splinting advantages, it minimizes movement, because you see, you're trying to stabilize that. If there was a compound fracture or the bone was fractured completely, and then we take an example of a leg, it is going like it's moving not controllably. So it means that the bones will be grinding with the muscles, and then the nerves will also be part of there. Then it is able to prevent additional injuries, because when the leg is flowing and the hand is not sprinted, it means we'll have further injuries. Then when you immobilize that part or that broken bone. It means you have reduced the amount of pain that this person is going through. When you control the breathing very nicely, it means no blood. Then from there is, if it was a closed fracture and you sprint it well using the available resources, this means like we can have a piece of wound. If you have a piece of wound, you need to pad it. You need to use some pads so that it doesn't cause more harm to the patient. So how to rearrange a deformed extremity? You compare the injured one and the uninjured one. So when you're doing that, you need to know if one leg is shorter than the other one. So that's why we try to employ the manual, traction, and stabilization. So there it is. You see, you have to be two of you. One responder holds the place where there is an injury. So between the hands, that is where the injury should be. And then the other responder will help you to align to a position that it will be less painful and the patient will be comfortable with. So if it is not aligned, it increases the chances of more damages, the arteries, the veins, the nerves. And then the moment you transport the patient in either in the ambulances or in our fire engines, as it hits on the speed bumps or in the potholes, it means like the handle or the extremity will be moving, and then it will be more painful to the individual. So this is what we are saying about the guidelines. One responder grabs the distal extremities, while the other person, you make sure your hands, your both hands, one is on the above the injury and the other one is below the injury, so that you can be able to stabilize that. Then the other person holds generally and manually tractions to a position that is more manageable and the patient is in rest pain. Then that's where we do slow motion and slow movement until we achieve the common, or we achieve a proper motion. And then we sprint it. This can be done by use of locally available materials. We can say like we have the rigid, we have, basically we have three types. We have the rigid. We can get a rigid out of a piece of wood. We have formables. That's when we can use a pile of papers, box, and then you have the traction sprint that can also help. We can also bring. If we go to the next one, you'll see these are commercial springs and accessories. We have a commercial spring, we have muskets, we have a spine board, we have rigid. Those are the commercial ones that if you a department can be able to buy them. That's what you have. But we said like we focus on what we have in the field. We cannot stop to emphasize more on the life-threatening. These are the ABCs. ABC can kill the patient very fast. Then you need to expose that site. Do not sleep. Do not strip, that is. You need to expose so that you can be able to see, is it an open fracture or a cross fracture? Then we said we need to check for CSM, C, which stands for circulation. We need to check for sensation, that is that part sensible? Is that part, the nerves ending, are they functioning well? Then we need to check for motor function. We tell them, please, can you be able to wiggle your toes? Then align the long bones injuries to anatomic position. You compare with the injured leg with an injured part so that you can be able to know exactly. Then for me, I always say, if I go to that part, or if I go to a scene of accident and see whatever is happening, I need to check on myself first. I am normal, so that you can be able to give care. Then in case you find protruding bones, maybe the lips, you find some bones on the hand, on the legs that are protruding, please try as much as possible not to push them inside, because you will end up causing more harm. So when you're immobilizing, make sure you immobilize both the injured site and the adjacent joint. So if it's the leg, you need to check, you need to immobilize the wrist, the elbow, and also the shoulder. If it's a leg, check on the ankle, check on the knee, and also check on the hip. Then before you splint, before you lift the patient from the ground to the spine. So then if you have some parts that are delicate or critical, please make sure you pad them so that to avoid further injuries. Yeah, we're still moving on. This is what we call the hazards of splintings, because it has its disadvantage. Because if you do it so tight, it means you'll have used the splinting mechanism as a tourniquet. So then the other thing is we need to make sure you do the ABCs before sprinting. Do not tighten, do not too loose, and then if you try to sprint a deformed extremity without you doing the manual traction or the anatomic positioning. So these are complications that can come across, that can come up on when we are sprinting, or we are taking care of our victims. So of course, take appropriate standard precautions. These are use the basic body isolations. These are the protective. The PPEs have to be used. If it's possible, expose the area. If you can't do it on site, you can create a barrier where not everyone can be able to throw their eyes and take the photographs to post them. Then manually stabilize the injury site. That's what we're saying, that it helps to align both parts of the extremity or the injured part. So there it is. Make sure gloves are always on. PPEs must be on, and then we can move on. You stabilize above the injury, below the injury, and then the joints adjacent. So when you check in for, after you do the sprinting, we need also to check to do assessment. Check for circulation, check for CSF, the sensations, and then check for motor function. This is to help you understand, before I had circulation, do I still have it now? Is a yes or no? If I don't have it, you go back to what you've done. You have to recheck. Then, have I done a good arrangement with the deformity, so that you check the part that is injured to the part that is not injured. You check, you see if there is change. So after that, that's why we said we need to check for parts. Check for parts, check for everything. This will help you understand what you have done. Is it right? Or have I done something that was not good? So we move on. So when you're doing sprinting, we need to get an estimate, a rough estimate of what we do. So we need to measure. So when you're measuring, you need to measure using the uninjured part so that it will give you a hint of what to be expected on the other part. So you measure from one side and then you move it to the injured part. That gives you a quick thing. After you do all that, we always emphasize that you check on the other side and on CSM. Then of course, secure the sprint and we can go to the hospital. So we go to the next one. So traction splints, mostly they're used in long bones. For example, the femur, the tibia, and the fibula. The TF, what we call the tibia fibula bones. It can be by unipolar, bipolar, it's one side, bipolar is two sides. So most of them can be, you can use it. When you, for example, the patient leg, you need to use it from the ankle all the way to the upper hip. Because we need to immobilize the joints, the ankle, the leg, and the hip. So that's why we say they can be a little bit bigger and a little bit heavier, depending with the type of material that have been used to create them. Then everything goes back. ABC. That's why it is always on each and every slides, because if you become an infected person in the process, you cannot be able to help if you are injured in the same. That's why I say, please make sure you take care of yourself. Manual stabilization of the leg and then applying is something that just an overview, but it's something that most of us we need to learn in both physical classes. So we always say that this just gives you a hint. So then assess the CSM and then adjust the sprints to a proper length depending with the person you're using it. So if you have the straps, the truncheon machine that has the straps, please secure them. If you don't have them, you can also use bandages that are that are locally available. You can also, if you have the manual, the commercial one, they come with these straps, the ankle hitch straps and also the straps. It comes with them, but if you don't have them, that's where we have to. I know firefighters are good in knots, so we always look for a way to supplement what we have. Then, of course, they must be secured very nicely. Everything that we do, we need to evaluate. Check for CSM. Check for the kind of work that you've done. If it's appealing to you, it means it's also appealing to someone else. Then when you're securing the patient, make sure we secure them comfortably and we keep on reassuring the patient on the progress. This is what we are saying. You see, if you look at the first responder, the gentleman there, is actually holding, we assume like the wound, it is between his hands. So he's manually stabilizing that leg, pressing it to the floor because the floor is rigid, and then you hold it there. Then the second responder, the lady, she is checking on the pulse. We're checking for circulation. That's why then you tell the patient to try and wiggle the toes. You see if the motor function is there. Then you try to pinch their toe and tell them if they can feel that. So you see, when you actually manually trunking the leg, one hand goes below, just above the ankle, where there is this void that is very much available to to everyone, and then the other hand goes straight on the heart below the toe as they are holding it, and then the lower hand pulls, and then the upper hand slightly pushes, like they're stepping on gas. You pull and then you push, so that now the whole leg can come. This is what we're saying. Now you need to measure the sprint using the uninjured leg, because it is adjustable. It has some adjustments. So you adjust according to the height or to the length that you need. That's when then you transfer the measurement now to the injured leg. Then this is what we're saying. We need to strap them well. You need to secure the spring. See, they have one goes above the knee, the other one goes below the knee and above the ankle, and then there is one that holds. If you look at the next, the one that is circular in the ankle, it is actually pulling the leg to the far end. So here we go. I'm also doing, I don't know if this video can, but okay, so it's supposed to be a video, but I don't think it will play. So emergency cares for specific injuries, we're just going to learn a couple of them so that we can sum it up. So we will patient assessment for pain in the shoulder, drop shoulder, and also severe blow to the back of the scapula. We're going to do some, basically means the same. We need to check on the CSM, then use a sling and a swath. I know most of us can be able to do that. If you cannot be able, please organize with your department, then you can have a training session for them. So then a caution here: if something is bent, do not force it back. I know we have seen a lot of movies that someone puts a stone or a piece of wood below the armpit, and then they just hop in and the shoulder is back. Please don't do that, because it has some, you don't know what happened. So you might end up causing more harm. So pelvic injuries, they are very common in high velocity or motor vehicle collisions or road traffic accidents. It's very some of the things that I'm sure we always face most of the cases. It is very painful. I came across a patient who had this, and they were crying out of pain. So we're going to see how we can be able to do that. It is pelvic is it's a killer injury, or injury to the pelvic is so critical, because we have a lot of spaces that they can stop blood. So patient care, move the patient as little as possible. Do not move on them. If it is not necessary, please don't move them. Then you check for CSM, these both legs. Then you straight, if you find their legs straightened, let them be straightened. If you find their legs a little bit bent and the patient can talk, the patient can give you the result of what you're doing and listen to them. If the patient is unconscious, everything you do, please remember to keep your eyes on facial expression. That's where they'll be able to tell you everything. If it's painful, they'll move their face and then they'll try to tell you to stop. So then, of course, assume a spine injury with everything with pelvic injuries. So care for shock provides, if you have ambulances en route, please advise them to give this patient some good oxygen, because it helps them, it eases. Oxygen is always a medication. Then these are patients that need to be transported as soon as you notice them. So we have some commercially available pelvic wraps. If you can be able to, if your department can be able to buy them. You can also use a piece of sheet, lap it very well, and then use it as a pelvic wrap. If we go to the next one, these are commercial spring. It gives you, it's actually calibrated depending with the size and type of, and the amount of pressure you can put in that. But we also have the ones that, we have one that we don't, these are sheet, basically, So these basically are a piece of sheet that you use it. When you using a piece of sheet, it doesn't have calibration of how much you can use it. So here, it is you to use your abilities. Number one, it shouldn't be so tight and shouldn't be so loose. So this one is when you trust your judgment over that. That's how it's done. Make sure it's about 10 inch. And then hold one side, cover, when the patient is already over the spine, get the two sides, and then you twist the one side over the other one until you feel is time. Don't do it to the extreme, because you might end up causing more harm. So the same case with the hip, you can never know the extent of the injuries. So we treat it as a pelvic injury. This one will give you some hints. We will have some abnormal deformities. We'll have some, the leg might not have sensation. So these are critical. These patients will not be able to move their toes or to wiggle their toes. So assess for CSM, always, we need to check for sensation, we need to check for motor function, for circulation. And then when you're moving this patient, you have to move them as one unit. Then this was said, immobilize using by either a pillow or a blanket, and then just secure the patient into a spine board. Then make sure you care for shock. How do you care for shock? Check if the patient is breathing from anywhere. Then you control the breathing. If it is cold, if they complain about cold, you cover them. If they want something to drink, please don't give them something to drink. if the EMS or the ambulance guys shows up, tell them, then they will give this patient some fluids. Oh, that's what we do. They will give some fluids through the veins. And then transport this patient as soon as possible and let them go to the hospital ASAP. So geriatric, these are the old patients. They're very, it's something that is common to the old people. When they, as time goes, as they age, they tend to be, they can fall at any minute. And they can hit something and then buff, they're already down. So when you're caring for them, you need to go an extra mile. You need to be very careful with them because they will tell you they are feeling pain in one part and then there'll be swelling. They'll be unable to move the limb, unable to stand. And the care is always the same. Yes. So this is what we're saying, like the surrounding tissues will have turned the color. So we have caring for a patient with a hip or a hip injury. Please make sure you pad them between the legs. That's why we say you get a blanket, fold it between the legs. Also, you can use a pillow if you have a pillow. Then sprint both legs so that you minimize movement. Like so in the picture, you can see that in the picture. You see, inside between the legs, there is either a soft blanket or a pillow, which acts as a barrier so that the legs or the bones between the legs cannot grind through, and then you'll not cause more harm. So femoral fracture.
Right, Richard, I think we're gonna wrap things up right there. We're at the top of the hour.
Sure.
Want to give a couple final words?
Yeah. Generally, when you're caring for wound or any injury, please let's make sure remember to have some. You see, we have repeated this word CSM and precautions. The PPEs must be done because we're trying to make sure like whatever the patient has, you can't get it. So let's check on CSM. That's circulation first because that is what will kill the patient. Then check on breathing, check on circulation, and then airway. Those are the key things when we are controlling such things. Chief Mike, thank you so very much.
Excellent. Thank you, Richard. Thanks for being here. And thank you to all of you out there for joining us for today's training session. That earlier in the chat, I dropped a link to a Google Drive folder where you'll be able to find a recording of today's training as well as a copy of the slide deck if you'd like to check that out. So thanks everybody for coming. We're going to wrap up the formal portion of the training here. If you've got the time, I invite you to stick around as we transition into our tea time. But let me just conclude with a big thank you to everyone for coming out. We don't take for granted the fact that you guys are using your time and your bundles to join us to better your knowledge so you can better serve your community. It's much appreciated. We've got plenty of space here in the training. If you know somebody else who might benefit from this training, please feel free to share the link and let them register as well. Plenty of seats available for more folks to come and join us every week. Alrighty, thanks everyone. Hope to see you all again next week.